Yeah.
So we wait. Okay.
Now live streaming starts.
Hello, Mingalawa. I would like to say thank you so much to the Professor Jerome Digozi and then Dr. Stéphanie Motton, and giving your time for the medical education program for the Myanmar and for the NUGMOH and for the revolution of Myanmar. And now, revolution has been almost 2 years. And now, currently, we control about 60% of the territory in Myanmar. And then those areas, we need medical services. And then we are giving medical services with a very critical and difficult time. In this time of critical and difficult time for Myanmar, and helping from the France, Professor Jerome Digozi, and then all the physician and surgeon, and then specialist non-gynecologist, Dr. Stéphanie Motton. And then she's going to give us a gynecology emergency. That will be very, very helpful and useful for us. And I would like to request Professor Jerome Digozi to introduce Dr. Stéphanie Motton. Thank you, Jerome.
Thank you, Zo. So it's a pleasure for me to introduce Dr. Stéphanie Motton. She's a specialist in gynecology surgery, and she's very famous in France. She's very famous for robotic surgery, but also for other things, and also for rehabilitation for women after surgery for cancer, and they can rehabilitate by practice of sports. So she's very famous in most fields around surgery. But today, I think it's a very important part for you. She will speak about emergencies in gynecology. I think it's very important for Myanmar people. So thank you very much, Stéphanie, to participate to this lecture. And you can share your screen and speak. Thank you, Stéphanie.
Okay, thank you for the invitation, Jérôme and Zo. Now I share my presentation. Okay, that's good for you?
Yes, it's okay. You can start. Mets-le en grand et c'est bon.
Okay. Okay. Okay, I'm going to speak about emergency in gynecological surgery today. In the first part, we will focus on the first trimester bleeding, because it is important that emergency physicians recognize patients with vaginal bleeding who may have an adverse outcome if misdiagnosed or not treated approximately in the emergency department. Causes of first trimester vaginal bleeding include implantation bleeding, spontaneous abortion, ectopic pregnancy, lesions involving the female reproductive system, perineal area infections. The problem is, The problem is vaginal bleeding during the first 3 months of pregnancy is a common event, from 10 to 25% of consultation in emergency. It is most frequent reasons for consultation in the emergency room, and the early diagnosis of pregnancy has two consequences to have difficulties for pregnancy localization. For beginning, a clinical case to understand better, I think. An example is a 25-year-old patient arrives at the gynecological emergency department for metrorrhagia. She says she has a positive pregnancy test. And now what questions do you ask her? You have to understand background to begin. Medical background about pathologies of hemostasis, autoimmune disease, surgical background, abdominal surgery, pelvic surgery, infections, gynecological background, regular monitoring, cervical cancer screening, menarche, menstrual cycle regularity, and obstetric background, gestation, parity, spontaneous absorption, ectopic pregnancy, and treatment. Familial background, especially for coagulation disorders, if she has a contraception, hormonal or not, tolerance, etc. And if she has a current treatment, has an anticoagulation, and the comorbidity has a smoking, alcohol, drugs, etc. For the pregnancy diagnosis, you have to calculate the theoretical gestational age. If not, you have to do a pregnancy test. And you see later, but you need to ultrasound to understand if it's a spontaneous or induced pregnancy. And be careful, you see again later, because it's a big message today. When the woman with a pregnancy present metrorrhagia, you need to know, you have to know the rhesus group, because if she is negative, you have to inject anti-D immunoglobulin, Profilac in France, sorry. Okay, now diagnosis. You have to understand, you have to know how metrorrhagic, color, abundance, especially abundance, pain, the topography of pain, intensity, type, mode of onset, evolution, if she takes an analgesic, if she has sympathetic signs of pregnancy, has a breast tension, functional urinary signs, functional digestive signs, has a nausea, vomiting, transit disorders, and you have to looking for general signs, has a fever. Important is a constance, if she has a hemodynamic tolerance with a blood pressure, pulse, temperature. You have to do abdominal palpation and to looking for spontaneous or provoked pain, localization, lateralization, defense, contracture. With a speculum, you have to looking for endouterine or cervical vaginal origin of the bleeding, appearance of the cervix, ectropion, bleeding on contact, polyp, profuse bleeding, debris being expelled. The vaginal examination with touching, open cervix, uterine volume, pain on uterine mobilization, painful of posterior cul-de-sac, bimanual palpation with the abdomen. our clinical case. This young patient is a neurologist, only history being chlamydial salpingite 2 years ago. She has smoking 10 cigarettes a day since the age of 15, sorry. She stopped contraception 2 months ago for desires to become pregnant. Date of last period, 38 days or 5 weeks of amenorrhea plus 3 days. She has a positive urine pregnancy test 3 days ago. His blood group is O negative. She reports low abundance dark red bleeding for 25 hours associated with some pelvic pain in the form of spikes with a rather morning sickness. She didn't take any painkillers. Examination is tension 11, 8, pulses normal, temperature normal. She has a lower abdominal pain, no contracture. On the speculum, the cervix looks healthy. Few metrorrhagia of dark red blood come from the endocervix. On vaginal examination, the pain is exacerbated on the right without perceived lateral uterine mass. What complementary exam do you carry out in the first intention? Evidence is ultrasound. You have 2 ultrasound for the abdominopelvic approach, always in first intentions, then vaginal approach if you know if it's possible. The ultrasound helps you to do positive diagnosis, localization, dating of the pregnancy, progression of pregnancy, and you have to looking for echo severity criteria, has a hemoperitoneum, embryo measurement, embryonic heartbeat. The results of for the clinical case is absence of serious signs, has a hemoperitoneum. There is a thin layer of effusion in the cul-de-sac of Douglas, uterus with homogeneous endometrium thickened to 12 millimeters. There is no gestational sac visualized. The ovaries present a normal size and echostructure, and no lateral uterine mass is visualized. What additional tests do you perform? What are your diagnosis hypotheses? Quantitative HCG after preliminary, you have to know irregular agglutinin, and you have to have pre-op assessment with a blood test, catheters, anesthetic assessment. Any metrorrhagia of the first trimester is an ectopic pregnancy until proven otherwise. Other hypotheses, the most frequent is intrauterine pregnancy, too early to be seen, and spontaneous absorptions, non-scalable intrauterine pregnancy. If HCG positive, anti-day immunoglobulin administration for preventing rhesus alloimmunization for the next pregnancy. My computer slips. Okay. I don't know why. Oh, that's good. In summary, ultrasound in first intentions, HCG only in case of non-obvious intrauterine pregnancy, has a uterine vacuity or aspect of pseudo-sac or yolk sac not seen. The visualization of a yolk sac indicates the intrauterine nature of the pregnancy, but not its development. Just for example, this is a gestational sac with vacuity uterine. That is a uterus with endometrium, myometrium, 4 weeks amenorrhea. This is a folk sac visualized at 5 weeks of amenorrhea. Folk sac. This is a uterus, endometrium, the colon, and the umbilical vesicle. And this is an embryo visualized here, 5 weeks of amenorrhea plus 4 days, 2 millimeters. This is this result show intrauterine pregnancy and eliminate ectopic pregnancy. This is ultrasound for 6 weeks of amenorrhea plus 4 days. We can see cardiac activity, 8 weeks of amenorrhea, and 10 weeks of amenorrhea. We can see embryo, and we can measure it. Okay, now we see especially ectopic pregnancy. The natural evolution is tubal rupture due to excessive distension, after then hemoperitoneum, then hemorrhagic shock, then exceptional death. The risk factors of ectopic pregnancy is impaired tubal mobility because of tubal trauma, background of ectopic pregnancy, tubal surgery, abdominopelvic surgery with adherence, endometriosis, and factors slowing the progression of the egg has a tobacco, microprogestagen pill, the background of vitro fertilization, intrauterine dispositif, and the maternal age superior to 35 years old. The clinical forms are erupted ampullary hematosalpinx, the more frequent, with 95%, delayed menstruation, dark red bleeding, lateral pelvic pain, painful pelvic mass. The diagnosis could be confirmed by HCG and pelvic ultrasound. and tubal rupture with signs of shock, low blood pressure, tachycardia, pallor, abdominal defense, and abundant hemoperitoneum on ultrasound, especially on the Morrison space. Any pain or vaginal bleeding in a woman of childbearing age is an ectopic pregnancy until proven otherwise. Here, on this ultrasound, you have at right the uterus with a pseudosac, and at left the ectopic pregnancy. The ectopic pregnancy is the consequence of diagnostic tripod: clinical, with a pelvic pain, vaginal bleeding and abdominal contracture, SCG, if is superior 3,500, and uterine vacuity. This is a strong suspicion. If less than 100, 500, and uterine vacuity, you have difficulties for pregnancy localization. You need SCG kinetics at 48 hours and informing the patients about the risk of ectopic pregnancy and rupture. If at 48 hours, if increase less than 15%, strong, you have strong suspicion of ectopic pregnancy. In doubt, you can release new SCG at 48 hours, or discussion about curettage with a search for placenta villi at a pathologist, with a pathologist. Ultrasounds for research of serious signs has an intra-abdominal effusion and lateral uterine mass, hematosalpinx, uterine vacuity, or pseudo-gestational sac. Here you have at left or right ovary, and at right ectopic pregnancy visualized. This is effusion in a cul-de-sac de Douglas and uterus. This is in laparoscopy effusion in a cul-de-sac de Douglas. What's the ectopic pregnancy treatment? You have two cases. If the ectopic pregnancy is asymptomatic with a serious signs, effusion, HCG superior 5,000, or lateral uterine mass superior 4 centimeters, or pain, or embryonic cardiac activity, or non-compliant patient, you have to do surgical treatment. If the patient is asymptomatic, she presents no serious sign, no risk of tubal rupture, no contraindication, and if medical treatment is available, you can do medical treatment with methotrexate. Surgical treatment is, if possible, by laparoscopy for decrease the risk of adherence for fertility. During a preoperative assessment, you chose salpingotomy, and in this case, you have to control ICG until negative, or if bad tubal condition, you have to do a salpingectomy. This is the ectopic pregnancy in the fallopian tube. And now you can see salpingotomy, opening the tube, extraction of the pregnancy, and aspiration in the tube. Extraction of the pregnancy. And this is a salpingotomy. You have to coagulate with a bipolar tube and remove all the tube. Okay, now just you have to know the other terminated intrauterine pregnancy is intrauterine pregnancy and not ectopic, which have to consequence metrorrhagia. The miscarriage being expelled, you need to do aspiration if hemorrhage and transfusion if necessary. The second case is a terminated pregnancy with a clear egg. The aspiration is necessary if craniocaudal length superior 25 millimeter or superior 9 week of amenorrhea. And the third case is uterine retention, and you have to do aspiration if the retention is superior to 15 millimeter. You have to reassure patients because it is a common event, and in 80% of cases, there are chromosomic anomalies. Be aware, just be aware of the hydatiform mole. It is a multicystic trophoblast degeneration. The patient has sympathetic signs of pregnancy, very high as HCG. The risk is a choriocarcinoma risk. Today, we can see the detail of this pathology, but you have to have this suspicion in your head. The ultrasounds for that is can helping us with because you can see anechogen cystic honeycomb or snowstorms intrauterine image. This is a hydatiform mole on the ultrasound and for pathologic examination. Any vaginal bleeding in a menopausal woman is a cancer until proven otherwise. At left, you have a cervical cancer. You can see the mass on the cervix, And if you see that, you have to do biopsy. That at right is ultrasound of endometrium with thickness superior to sometimes 2 or 3 centimeters. In this case, you have to do curettage. Okay, and you can see now genital infection because it's a causes of consultation in emergency department. This is the evolution of the pathology. It starts with inflammation. The inflammation is a salpingitis, then edema. This is hydrosalpinx, and the natural evolution after without treatment is pure salpinx with a pus in the tube. Clinical case now. Just for example, 28-year-old patient arrives at the emergency department for fever and right pelvic pain. She had a pregnancy and gave a birth in 2019. She had IUD contraception for 8 months ago. Clinical examination shows a dirty local painful uterine mobilization at vaginal examination, and right pelvic contracture on the abdomen. What do you suspect? Evidence is upper genital infection. She is the same. What exams do you require? You have to do blood count because this can show hyperleukocytosis, CRP increase, HCG negative, and ultrasounds show see later. You can see later bacteriology on local and serologies of sexual transmitted disease as a chlamydia, mycoplasma, VIH, etc. What treatment do you do? In first intention, you can hospitalization. You have to do hospitalization and intravenous antibiotic in accordance with the recommendation of the country, and IUD removal. After 4 days, the treatment is ineffective. What do you suspect? In this case, pure salpinx. What do you do? This is the ultrasound. You can see at left ovary, and at right, big pyosalpinx with a pus in the tube, with a level in the tube. This is a laparoscopy. It shows us bilateral piosal bunks, as we can see. This is a pus in Douglas. The treatment is laparoscopy, salpingotomy, tubal washing, then peritoneal washing, and you need to do a drainage with a system of aspiration and lavage. If you have a pus in Douglas, the drainage consists to do after operation lavage 3 liters by serum for 24 hours for the first days, the first and the second days, and after when the liquid arrives very clear, you can stop the lavage and finish with a simple drainage with this system. Okay, just this case is important in the postpartum. Be aware of the postpartum endometritis. This is the same case plus postpartum situation. The risk factor is a difficult labor, cesarean section. The patient presents a full lochia, and in this case, no surgery, but the treatment is antibiotic. And only if you have a retention of placental debris, you need to do curettage, and this curettage to be considered 48 hours after the start of antibiotic treatment. It's very important. The take-home message is any pain or vaginal bleeding in a woman of childbearing age is an ectopic pregnancy until proven otherwise. If you have not laparoscopy and you have a serious sign, you have to do laparotomy. Don't forget, in case of metrorrhagia in women in childbearing age, rhesus. If rhesus negative, you have to do prophylactic injection of anti-D hemoglobulin. Reassure patients because not ectopic but intrauterine abortion is a common event, and in 80% of cases there are chromosomic anomalies. And any vaginal bleeding in a menopausal woman is cancer until proven otherwise. And in this case, you need a pathological examination of biopsy or curettage. Thank you for attention. If you have any question, I can answer. I try.
Thank you, Stéphanie, for the lecture. Thank you. I think now we have some